Hello, and welcome to the Rest, Repair, Recover podcast. I'm Susie Bolt. This is a space for anyone who's navigating chronic illness. We are here to share real stories, helpful insights, and honest conversations about what it really takes to help yourself heal a tiny bit every day. So whether you're in bed listening, you're on a gentle walk, or you're just needing some company as you go about your day, I'm so glad that you're here. So, good afternoon and welcome to anyone who is listening to this. It could be morning, evening, or afternoon, wherever you are. I am delighted to have with me today Dr. Paul Glynne. Now, Paul Glynne has been one of the doctors that many people are finding their way to after not really getting very satisfactory help in maybe perhaps the traditional kind of routes that are available to us as patients right now. And I think I'm right in saying that you've been getting more and more long COVID patients and sufferers coming to you looking for some kind of advice and support. So what I'd really love to hear from you is just first of all a little bit about you as a doctor. So what do you kind of specialize in? What's your thing? So that everyone who's listening can kind of go, okay, that's why people are finding this one
Mm.
rather than someone else.
Well, I'm a good old-fashioned consultant general physician,
Yeah.
and I work in the NHS at University College Hospital. And my background in medicine is in general medicine and intensive care and nephrology. And gradually over the years, my career has sort of meandered, as it often does in medicine. And I found that really my main interest in medicine was in general internal medicine rather than specialty medicine, because I always enjoyed the variety of general medicine and seeing de novo clinical presentations. And with general medicine, you would often be referred patients who have unexplained symptoms that don't automatically fit into a single specialty. And so it just really happened that over time, I've become more and more interested and seen more and more patients who really fall into the category of unexplained symptoms that patients have often been around the houses and seen multiple doctors and lots of tests and still haven't got answers. And that's really how I've developed my clinical career. And I've done that both in the NHS and over the last 10 years in the independent sector, where I set up with colleagues, the Physicians Clinic, which is a multi-specialty physician clinic, because I really wanted to be able to work with like-minded people who are passionate about medicine. And I think it's important to say that as a general physician, I would often be referred patients with post-viral symptoms. And so for years, I've been seeing patients who've had viral infections and various complications that nobody's really fully understood. But nevertheless, often still patients need to be assessed and listened to, and to try and develop strategies to try and to manage their conditions. So when COVID hit, I initially spent a lot of time working in the Frontline in emergency medicine at University College, and saw through the first and second waves the acute COVID presentations, and then gradually started seeing increasing numbers of patients, first who'd had COVID but been in hospital and then were having problems after that. But then I started seeing a number of patients that were being referred who'd had very mild COVID illnesses relatively, who hadn't been to hospital. Actually, at the beginning, some patients probably should have been in hospital, but they weren't for whatever reason. And it just really took off from there, because I began to see more and more post-COVID problems. And as the field of post-COVID, long COVID medicine has evolved, I have developed an interest in the field. I've seen more and more patients, and I think in an area where it's a new condition to some extent, and there's a lack of evidence on which to make robust recommendations for treatment. All you can do really is become an enthusiast for the field and observe. And to some extent, what I've done really is, and I'm sure that will come through in the question and answer session, is that I've taken a very consistent approach to the way that I've managed all patients, rightly or wrongly. But for me, that's worked because it's allowed me to make consistent observations, some of which we've written up. And, I'm not saying that my approach is the right approach, but it is an approach that I have, certainly the feedback has been generally positive. And it's allowed us to actually, number one, write up, fairly robust observational data. But also it's been used as a platform now to be able to apply for funding to undertake, more formal randomized treatment trials, which are just beginning to evolve. So I think that's really how I've got to where I am at the moment. But also on a personal level, it's been fascinating as a physician to see a new condition. It's been one of the most interesting times of my career because, like all careers, sometimes things stagnate a bit. You do the same thing day in, day out. And actually for me, COVID has been fascinating from that perspective. And it's really been great to develop a new specialty to some extent. And so I've really enjoyed that aspect of it and continue to do so. So that's how I ended up where I am.
Oh, perfect. It was almost like you were meant to be the person that, that people came to.
I've got plenty of excellent colleagues who are also in the same boat,
I'm sure,
but maybe
that's
from a
great.
slightly different angle. But yeah, there's an increasing number of us who are I would say enthusiasts for the subject and want to try and help and yeah.
There's something really useful about being a generalist here because, a lot of people have been sent obviously to, okay, you need a referral to cardiology, you need a referral to respiratory, and that's not taking the bigger picture of, and then the snapshot of what COVID does to someone's body. It's a very, very kind of narrow trench. And then people will say, oh, we can't find anything here, so it's not us, off you go again. So I love the fact that you're saying, I know enough about everything to be able to come up with something that I can work with, especially, with the conditions that people are presenting with. A lot of people, as you know, get these test results back, which say, no, according to our test results, everything is clear. And you can clearly see that a lot of people are not well. They're not making this up. So it's great that you've got an interest already, even prior to COVID, in the kind of the unexplained, the unresolved, and, for which, long COVID is one of those conditions, but suddenly, in a much, much bigger scale than we've ever seen before. So to have someone like you that, people talk about and can learn from through interviews like this will be really, really rewarding for people. So what I know is we have put together, so with my Facebook group, I've asked for questions. We've whittled them down because we obviously had quite a lot. And Paul's had a look, and we are going to have a bash at getting through as many of them as we can. You will find that, listener, Paul doesn't have the answer to everything because no one does. Okay. But we can talk about that when we get there. But let's kick off with, let me have a look at question number one, because I think we may have already, well, I'm not going to ask it, and let's see if there's something else that you can add. So question number one, as a doctor, how have your thoughts evolved over the past 2 years concerning the treatment of long COVID patients? Now, you sort of alluded to an approach that you take there. So let's just hear about that.
Okay, well, so my approach really has been really formulated from the observations that I've made from patients that I've looked after and from the feedback I've had from them and from other colleagues. And it really stemmed from the fact that if you look at the very first cohort of patients who had developed what we now define as long COVID, the vast majority of patients present with multiple symptoms involving multiple body systems. And if you track those patients over time without any intervention at all. So by default, the very first group had no intervention at all because people didn't actually really understand that there was going to be this huge problem.
No, I was
But the
in that
recovery,
group. There was nothing available.
exactly. But if you track what happens and you look at the rate of recovery and you look at the burden of symptoms, the rate of recovery is extremely slow.
Mm.
And although there is recovery, and it does vary between individuals, overall as a group, patients would often remain very symptomatic for months afterwards and possibly beyond. And actually, we've now seen so many patients, even 2 years plus down the line, unfortunately, still very debilitated with symptoms. So we know that the trajectory for recovery without intervention is extremely slow. And we also know that within that trajectory, there is a relapsing and remitting course. So patients describe repeated episodes of relapse and then feeling better, good days and bad days. Lots of descriptions like boom and bust cycle would apply to this, but it's very much a relapsing and remitting clinical course. And because it's so complex, if you just look at the clinical presentation, it's hard to believe that we are going to find one single biochemical, molecular, or cellular pathway or pathology that's likely to account for that entire process. So it's clearly complex, and it's complex in its manifestations. And therefore, it requires and demands a holistic and multi-system approach to management, because although there may be some, and we can talk about specifics about certain specific abnormalities that will require specific pharmacological intervention, actually, overall, it's very, very complicated. And that's why it's going to be difficult, I think, in terms of really finding, single therapeutic interventions that meaningfully change the outcome for that reason. So I think it's very careful, therefore, it's important how we design clinical trials, because they've got to reflect, from a pragmatic perspective, the complex nature of long COVID. So what I've tried to do with those caveats and limitations is say, well, how can we push the trajectory down? And any patients who I've seen will know that I really have based my strategy on trying to develop ways in that the speed of recovery can be accelerated. So you push the slope of the curve down. And I always illustrate this through drawing this graph, because for me, it helps me also understand what I'm trying to do. And so what is it? How do we achieve a faster recovery? Now, we can talk at length about emerging research and hypotheses about what causes the condition, but I can tell you what is consistently true. And actually, this has been my observation from the beginning. And I forgive me if I sound like a broken record, but I've given interviews and podcasts and written about this, and I have not changed my view in that consistently the same factors do seem to prevent that slope of going down, and that these are the factors that always cause symptom relapses and prevent you recovering. So they're always the same. Even though there can be a marked heterogeneity between presentations between patients, the same factors or barriers to recovery are always the same. So their sleep deprivation is probably the worst. Stress on the body, and that could be physical stress, it can be mental stress, it can be intercurrent illness. They all cause recurrent or relapses or stop patients improving. Over-exertion is a very common one. In fact, so many patients I saw, less so now because I think people are becoming more aware of the risks, but the number of patients I saw last year, particularly younger patients who really started exercising far too early after their acute illness, who deteriorated as a result. It was a very familiar story that I kept hearing, but I think the message is getting out there thanks to patient groups, because it's certainly not a public health message about how you rest and recover from acute COVID.
People are still being told to exercise.
Yeah, so that is about the worst thing. Yeah, it's about the worst thing you can do, particularly early on. So and it's not just physical exercise, but it's also brain exercise, it's cognitive exercise, because that has exactly the same detrimental effect on patients who have post-COVID syndromes. And then we've seen the importance emerging of gut health. And, you have a poor gut health, really bad, major barrier to recovery. Actually, some interesting data emerging about how important gut health is in improving outcomes from long COVID. And then some of the work that you'll see myself and actually my wife, Sarah, work on is about how important in certain groups about hormone health. And we've seen, countless women in their 40s with accelerated perimenopause triggered by COVID infection and probably in some cases COVID vaccination. So all of these factors, they are huge stresses and they so before you do anything, if you can't address those barriers to recovery, then I don't think the patients will improve. So you can try any pharmacological intervention that's banded around, and there are many. But if you do not treat those barriers to recovery, I think patients, without exception, really struggle to recover or get onto a better trajectory for recovery. And there are many ways in which you can address all of those. And, we can talk about some if you wish, but addressing them is really key. And then on top of that, there are specific pharmacological medication interventions. Now, I've taken a particular interest in the use of antihistamines, but there are others, and there are others specifically for organ-based complications. So the obvious one is autonomic dysfunction requires specific medication therapies. Cardiac inflammation warrants specific medication therapies. And there are others, but the strategy is really very simple. It's managing those barriers to recovery and then considering or trying to tailor specific medicines. And it's not just about medicines, by the way. I mean, I am a fairly conservative, London physician. So obviously I have a degree of expertise in using medication, but I'm equally, aware of the power and importance of non-pharmacological interventions like your own in managing long COVID. So it's not just about that, but I can tell you what I'm good at doing, but I will defer to others who have greater expertise in other fields. So, and that's why it's important to have a range of practitioners who are really have got the same shared interest in the field, but offer something different. And I think as long as you do no harm, and as long as what you do is safe, even in the absence of evidence, I think it's safe and you're carefully observing and auditing what you're doing, then I think it's reasonable. And, we've got some very, very good results. We're just about to write up our latest cohort, and I think there's over 300 patients in that group. And we've got very consistent results and in terms of response. And interestingly, I can't give you the definitive information today, but my colleagues who have been doing all the laboratory work may have even found some signals not only related to long COVID, but also to what might determine who responds to specific treatments.
Oh, interesting.
So that's really interesting work, but it's observational, but nevertheless,
you
have to start somewhere. If you look at every discovery in medicine, it's always started with making simple but consistent and well-recorded observations. You can only start there.
Yeah, absolutely. Oh, it sounds fascinating. And I love to hear you talking about the stress piece, actually, because I think most people are beginning to really come to terms with the fact that stress, as physical stress and mental stress, it's not just about managing that exercise piece. It is about managing just the emotional burden that this takes on people, because their stress load goes up. You're not who you were. Your job is perhaps on the line. Your relationships are changed. And someone says to you, oh, actually, you're going to need to change what's going on in here in order for you to get better. And that's incredibly hard. And as you say, that's not something that can be treated with drugs.
No,
And so finding places like social media and stuff is incredibly important for people to kind of tap into, and I'm just talking about this because there might be someone who's only just kind of picking up on the thread of all of this stuff. It is so important to get the daily support for the psychological challenges that goes on with this journey. And I'm not talking about just going and seeing your GP for some antidepressants, although for some people that has helped. That's just one piece. It is about getting a group of people that support you and understand what's going on and can kind of travel with you on the journey, because it's hard. And to know that there are doctors out there that are saying, we get this and we see it and we understand all the pieces of this puzzle as much as we can right now, I think is really important. So hopefully, as well, we've got some doctors who perhaps aren't really up to speed as much as you are watching this at some point and going, oh, okay, great. This is really interesting to hear. I would love to, let's go into that antihistamine discussion because I had quite a few questions on it. So they were quite specific questions, but I know for a lot of people, antihistamines really have been a game changer, and they were for me. In the kind of month 4 of my kind of post-COVID infection, I was suffering incredible insomnia, and my doctor had tried a few different things, sleeping tablets, blah blah blah, and nothing was touching the sides. And then one day we went, oh, why don't we try this quite drowsy antihistamine? And I think it was Phenergan, which is promethazine. And not only did it help me sleep for the first time, but it also took the fire out of my body. That's how I described it, within 24 hours. And I was fascinated by it. So I started to kind of have a little bit of a dig around. Why has this helped? So talk to me about your use of antihistamines and what you see it helps people with.
So from our observations, what we know, so in around 90% of the patients that we've studied, we know that there is and what I would describe broadly as an aberrant T cell immune response to COVID infection. So the adaptive immune system, as distinct from the antibodies that are produced acutely in infection. That adaptive immune system is, the profile of those T cells is different in patients with long COVID. And that's compared to patients who've had COVID and then recovered normally without any complications. So there is clearly a difference in the immune response. Now that might seem obvious because there is a huge difference from those who recover compared to those who remain extremely ill. But it's the fact that you can identify it in blood work is useful because it's been very helpful for me diagnostically, particularly in cases where I haven't been sure whether they have got long COVID or another diagnosis.
Right.
And remember that not every patient I'm referred to with a post-COVID syndrome has a post-COVID syndrome. Most do, but some, it's borderline. And you get to recognize when you see so many patients where something just flags up in the history or the presentation is, hang on a minute, is that really what they've got? And so the ability to measure that for me has been extremely helpful from a clinical perspective, although it's not formally validated as a long COVID test, but for me as part of my assessment, it's been helpful. So there's a difference in that immune response, and therefore there presumably must be a difference in the downstream effects of that immune response, which is typically inflammatory, and inflammatory pathways are typically multi-tentacled. So it's almost like the analogy which I use is that when I was an intensive care physician, we always used to use the analogy that when you get an infection, an acute infection that overwhelms your system in a very rapid and devastating way, you set off a sequence of events, and it's almost like kicking over an apple cart. And that when you've kicked over the apple cart, picking up one apple is not going to change the fact that all of the other apples are lying sprawled everywhere. Yeah. And that is why, actually, interestingly, and I don't want to digress too much, but that is why every single pharmacological intervention in acute sepsis that targeted one pathway always failed. because it doesn't address the fundamental problem, and it doesn't address the fact that this inflammatory response has so many different facets. Now, I see long COVID as a slow burn of fat. It's not maybe as dramatic, but it has multiple different effects on the brain, the heart, the autonomic nervous system, the gut, the bladder, the bowel, etc. So it's and I think that the observations would support that. And parts of those manifestations in a small group of patients when we first saw were classically histamine driven. So there are a group of patients who get absolutely classic histamine driven symptoms, whether it be severe runny nose, itchy eyes, rashes, itching, to full-blown hives and urticaria. There's no doubt that in that group, and we know that all viruses can trigger urticaria. Post-viral urticaria is a well-recognized phenomenon. And so we saw many patients at the beginning with classical histaminergic symptoms. And so it was logical to treat them with antihistamines.
Right.
And what was interesting is that as part of that histaminergic response, we saw many patients with GI symptoms.
Yeah.
So lots of gastrointestinal dysfunction, pain, bloating that wasn't explained by a structural abnormality when you did tests like scans or endoscopies, and also multiple food intolerances. And alcohol intolerance is extremely common after viral infections.
Yeah.
And often
caffeine and sugar.
Yeah, and would
Right.
and could often trigger these very histaminergic symptoms.
Yeah.
And so it was logical and very simple to say, well, let's treat you with drugs that block histamine receptors, so the H1 and H2 receptor. And so we started to see that some patients say, wow, that really made a huge difference. Now, it doesn't cure the underlying problem, because ultimately you're picking up a few apples here and you're not lifting up the whole cart.
Sure.
But in that group, it really did make a big difference.
Yeah.
But what was then interesting is actually some of the symptoms that we did not expect to be treated by antihistamines also seemed to improve. So when we followed the patients, and I was very, very lucky, because one of my part-time medical secretaries happened to be paying her way through medical school by working as a medical secretary, and was very keen to get involved in research. And she has been absolutely fantastic. Without her, I wouldn't have been able to do any of the research, because she effectively has been a research fellow and has helped me, and Rajiv Gupta, our hematologist, and Vanya Gant, who's my infectious diseases colleague, really do a lot of the work in terms of data gathering.
Right.
And so thanks to her, we managed to get independently, so she wouldn't really know about the details, but we almost got an independent check on the symptoms before and after treatment. So it was as good as we were going to get in terms of the quality of the observational data. But we found that many patients who seem to respond to, I think, more to the H2 blocker famotidine that we use.
Yeah.
But things like the cognitive impairment and brain fog would often improve. Not in everybody, but in a fairly large number. And it was that which was interesting. And it was also the time course. So the time to response was often over several weeks. And of course, histamine-driven symptoms should respond over several hours, not weeks.
Right. Yeah.
So there's something about the modulation of histamine receptors, which is more than just blocking histamine production, which seems to be important. And if you go back to all the original in vitro 1980s data, what's interesting is that you'll see there's a whole load of data about using famotidine, and famotidine has an interesting range of actions, because of course it was very widely used, that class of drugs, as antacids back in the 1980s.
Right.
And they were superseded in the 1990s by what we commonly use now, which is the proton pump inhibitors like omeprazole and lansoprazole.
Yeah.
But back in the 1980s, the H2 blockers were first-line treatment. So there's actually a whole range, a wealth of literature about their cellular effects, and in fact, blocking histamine receptors on organs other than the gut in the brain and on T cells particularly, started to raise in our minds whether there could be some form of immunomodulatory action of these drugs on the immune system. And that's what we still think. It's a hypothesis, but the results are very, very consistent. About 70% of the patients respond over 12 weeks. And we've seen that really across the range of people that we've treated. And that's how it evolved. And we've continued to use that as an adjunct to treatment.
Sure.
But as time has gone on, it's become clear about, how important it is to address the barriers to recovery, the other specific problems related to autonomic dysfunction, all of the areas that you've discussed. And actually the neuropsychiatric complications of long COVID are extremely important because I absolutely acknowledge the psychological impact of debilitating disease and how that itself can drive the underlying problem. But it's also clear that neuropsychiatric illness is a direct result of COVID infection.
Absolutely.
In fact, autonomic dysfunction, where you get really very marked dysregulated sympathetic nervous system activity, itself is a cause of severe anxiety, particularly at night. And so it's a very complex area, but those issues are hugely important. And they do require, as you've said, many different approaches to management because, pharmacology might work for some patients, but it certainly doesn't work for all. Non-pharmacological measures work for probably many more patients, but really, and they're much safer.
Yes, right.
So
exactly. I don't think anyone's hurt themselves in our breathe classes or our relaxation.
The feedback I've had from your classes has been really extremely positive. And in fact, I remember really only about 2 months ago speaking to one of my patients at UCLH who had improved, but she actually told me that the one thing that she did that got her over the line, these are her exact words, was your program. And so I think as an adjunct to
a really important piece,
it's really important that these things are all done as part of a package of measures. And that approach in many patients is not in all, unfortunately, but in many is extremely helpful and successful. And it gets them to a stage where they're on that faster trajectory.
I call it the upward spiral rather than the downward spiral. And I think, it never before have people needed to learn so much about their bodies and how they work, the role of the brain and its kind of control of the immune system and actually how we do have influence, to some degree of what's going on. And actually, as you've said, to have more of a multi-system approach to recovery rather than just having it be focused on medication, I think is absolutely fundamental.
Yeah.
And not just for long COVID, for recovery in general from anything that's really difficult to recover from, because we really do need to get our brain on side. And I'm not just talking about our mind, I'm talking about our brain and its activity. And so, I really felt when I was in recovery myself, I can't do this on my own because actually it requires commitment, dedication, support, belief, hope, understanding, and inspiration. And I thought, well, I can't just get all of that by myself. I need to have others to do that with me. And I'm a social creature, as we all are as human beings. And we feed off that and we self-regulate and co-regulate with each other. So it felt like the most important missing piece at the time.
But, if you look at disease in general, if you look at the traditional approach to disease, it's very modern and traditional medicine, Western medicine. It's very focused on the structure of disease, the structure. And what I mean by that is that it's about abnormalities on imaging, on scans. So is there a structural abnormality to explain the symptoms that the patient presents with? And that's very much the approach that is taken. And, what is it that that is tangibly wrong in a diagnostic test. Because if it's not tangibly abnormal, then how can there be a problem? And that is where the whole system breaks down, because the brain and the nervous system, with all due respect to my colleagues in neurology, the vast majority of disorders of the brain and nervous system are either incompletely or very poorly understood.
Right.
And even the science behind some of the most common and devastating neurological and neurodegenerative diseases, although it's advanced, is still falls way short of finding effective cures for patients with devastating neurological disease. In fact, it's probably the specialty that has the fewest treatable and curable diseases. And that's the way neurology is. It's it's very difficult subject. And having had a father who had terrifically bad autonomic dysfunction from Parkinson's disease, I know what it's like to see someone deteriorate with that sort of problem. And the post-viral syndromes, they can cause equally devastating neurological symptoms that affect brain function, cognition, the whole function of the peripheral nervous system, how signals are processed, so that debilitating, severe, painful neuropathic and neuralgic pain can be disabling, is often not matched up with abnormalities in traditional testing. But clearly, when hundreds of thousands of patients are presenting with the same thing, it's it just shows that there's so much we don't know, and we know that there's a complete, the dysfunction of the nervous system is, I think, is another fascinating area of medicine, which I wish I could understand better, but I see the consequences of neurological dysfunction. Interestingly, just as a thing, is that neurologists have traditionally labeled a lot of these problems as functional neurological disorders. So patients who present with neurological symptoms for which you can't find an obvious cause are always labeled as functional neurological disorders. In fact, there is a website for patients, which is very good. It's called neurosymptoms.org, and it tries to explain what these are. But fundamentally, these are very significant, severe, and real neurological symptoms for which you can't identify a specific abnormality on a scan or a blood test, but they are definitely there.
Right.
And the problem is that we just don't understand enough to be able to understand what the precise problem is, but they're very consistent in their manifestation in each patient group. And it's much more actually really that they're dysfunctional neurological disorders. So there's, and I think what you say about how the processing of signals can be disrupted by a severe infection that leads to a complete change in the way that information is processed. That the only thing that really effectively can deal with that are, I think, non-pharmacological interventions that help to try and retrain your own nervous system. And, I think it's a very difficult thing to achieve, but in those that can do it, then I think it can be very effective. And I have seen a number of patients do that through various techniques, maybe through your own program, through others, where even they have been surprised about how effective it has been. And so, this is, again, a very an emerging area of medicine and neurology that's in its infancy.
I think so.
But at the moment, it's often we've got to get over the fact that because you can't see, an abnormal scan, that it must, this whole concept about it being a functional problem. And the implication of that is that, it's not a real problem. It's a function of something that you're either imagining is clearly complete nonsense. And it's usually often these sorts of things are derived from comments generally made by people who aren't actually looking after patients who are going through this.
Yes, we still see people being dismissed, and it's pretty difficult to support someone who's gone in. Perhaps they've waited 6 months for an appointment to see someone, and they are dismissed.
But
more than
Yes.
thank goodness there are kind of places where we can scoop people
Well,
up.
there are, and actually, there's a lot of there are a lot of really good physicians out there. I'm just
There
going to speak
are.
to the committee who don't take that view.
Yeah.
But I'm well aware because I've got some colleagues who I work with in the NHS, particularly, who are definitely of that view.
Yeah.
And I'm not quite sure what drives it, but that's a whole
It's a whole other conversation.
other
I know.
conversation. That's a whole
So
other conversation.
I was also talking with someone in my phone program the other day who had waited quite a long time to have a conversation with someone at the long COVID clinic, to be told by that person, you'll never get better. So you might as well find a job that's less intellectually taxing. And I thought, that's really probably the least motivating and helpful thing that you could ever say to someone who's going through this. So,
Yeah.
luckily she had somewhere to bring that to. But, on the contrary, we do get lots of amazing stories of great help and advice and doctors out there that have taken the time to sit with this new phenomena in the world and go, what's going on for these people? They're not making it up. Let's spend time really getting up to speed so that we can offer the best help and advice and support possible. But yes, sadly, there are still some pretty big horror stories out there. Anyway, let's get on with our questions because I'm aware that we could get lost down rabbit holes very easily. Okay. Viral persistence. Any thoughts on that?
So fascinating area. Again, I think it's fair to say that it's a field in its infancy.
Yeah.
Lots of interesting emerging work. It's a very attractive hypothesis because certainly we know that other viruses persist and other viruses are reactivated. And we know from some of the T cell work that I've done, which we're yet to publish, but we've definitely seen patients who look like they're actively reacting to something there and then in their system.
Yeah.
And for me, the only way that could be the case is either because they've got an abnormal memory of having had the viral infection, so immunological memory, which is an absolute recognized immunological phenomenon.
Yeah.
Or it's because they actually are reacting to the fact there's still virus there, or it's being reactivated, or that other viruses are being reactivated. And what's interesting is that again, I can only come back to our own observations because I'm most familiar with those. But what we see is that the specific compartment of T cells that are affected, and I'm not an immunologist, so I am reliant on my own colleagues who are experts who tell me what they think it means. But it does seem that it's plausible that these things might be involved in immune surveillance. So if there's a defect in immune surveillance, then it's possible that reactivation of viruses may occur more readily. And we know that there's definitely an emerging literature about EBV reactivation.
Right.
Now, whether
Yes, definitely.
and whether that's causing a problem or is just an epiphenomenon, we don't know. But it certainly adds weight to the whole question about viral reactivation. And therefore, could there be persistence of COVID itself? Now, I think there's more work that needs to be done because the published data is on relatively small series, but there's an increasing number of publications looking at evidence of viral persistence in different organs, and the gut, of course, being a key reservoir for that. So I think, definitely an area that I'm watching closely with interest. And I think it's a really interesting area. And of course, the obvious, simple conclusion from the question of viral persistence is whether some patients might benefit from prolonged antiviral therapy.
Right.
And that hopefully will form the basis of a future clinical trial. Now, I'm not aware that's going on at the moment. And of course, in the UK, anti-COVID antivirals are tightly regulated in terms of their delivery for specific groups. And that's quite right at the moment. But eventually, we really need to have a look at whether there may be a role for antiviral therapy in patients with long COVID. And if we can find markers for viral persistence that help demonstrate that it's there, that would be, really interesting and add weight to that. So absolutely, I think it's a really another very interesting field, and one of, I would have thought, the main sort of, if you like, tenets for in terms of investigation, in terms of underlying pathogenesis of long COVID.
What I will say to the listener at this point is, it's obviously we're hearing Paul saying this is really interesting. Research is underway, perhaps not on a large enough scale yet for it to be something that comes in and kind of really changes the ground. So just be aware that when we talk about research, it doesn't mean that in 6 weeks' time, there's going to be a solution and then, an answer. Okay. So just manage expectations on that one. It takes
and research, the lead in time. And the lead in time for this type of research can often be very long. I mean, it can take years to really develop this. It's not the same as developing vaccines.
No.
So, and I think there is a lot going on. But it is a sort of, it is a matter, unfortunately, of waiting to see what comes of that. But on that one, I think that's a really interesting area, and definitely one that's worthy of pursuing.
Yeah. Great. Okay. We're going to move on to the vagus nerve. Now, I talk a lot about the vagus nerve, and I think it is part of, that piece that we were talking about getting the brain to send the right signals back into the body, rather than the confused sort of scramble that it can find that it's sending out. So this is just a question that has been written here. Recent promising clinical trials have shown that long COVID symptoms have been improved by using TVNS, they're the kind of vagus nerve stimulating devices, antihistamines, and also probiotics. We know yoga, breathwork, and meditation help. Are these results connected in some way? They all seem connected to the vagus nerve. Is COVID damaging the vagus nerve? And if so, how do we repair it? Or is it something else? Your thoughts?
Well, so I have seen some patients report that they've had some improvement from vagus nerve stimulation.
Yeah.
It's not a field that I know a huge amount about, but I do know that autonomic dysfunction is extremely common after COVID-19 infection. And that one of the likely causes of that is disruption of the vagus nerve, so that you get a sort of this disparity between sympathetic and parasympathetic signaling. Now, well before COVID, post-viral dysautonomia has been well recognized, and the concept of there being a vagus nerve neuritis, so a direct inflammation, has been bandied around for some time. And I think that's an attractive hypothesis, as is the whole role of autoantibodies in autonomic dysfunction. But one of the issues that we have so far is that it's not yet proven in terms of pathogenesis. The field of autoantibodies is often somewhat contentious in that you don't quite know whether a finding in the blood is an epiphenomenon, so it's a result of some inflammatory process, or whether it's actually causing the underlying disorder. So I think it's a work in progress, whether there is a connection between vagus nerve stimulation, improving gut health through probiotic therapy, and the meditation and mindfulness and recovery program techniques. I don't know. I mean, it's entirely plausible that through improving gut health, that your immune system would benefit from that. And we know that there's clearly a link between immune health and gut health, and whether or not that then has an impact on the ability of disrupted autonomic nervous system to recover, aided by these other approaches. It's entirely plausible, but I don't really know any more than that. All I'd say is that vagal nerve stimulation is safe.
Yeah,
It works for some, but not others.
sure.
Um, but but the gut health and the sort of recovery programs that you offer, those things I think are likely to yield the most value in my experience.
Right. Well, I think, just for the listener who's perhaps coming to hear about their vagus nerve for the first time, one of my students a while ago called it the Viva Las Vegas nerve, which I quite like, because we talk about it a lot. Um, Essentially, my experience of it in a really simplistic way is COVID for me kicked off a massive shift into the sympathetic overdrive. And I just couldn't find a way of getting myself back into that parasympathetic activation. And then I realized actually the way that I can do that is by using what I do for a living. I can regulate with yoga and breathing and deep relaxation, essentially taking this kind of heightened state and going, okay, let's shift you over here. And the body wants to go back up there, and you just keep doing it, and you keep doing it until you stay there for longer and longer. Because it's almost like the vagus nerve loses tone and it stops being able to help you shift into that rest repair mode. And so just by doing that work, actually making your body and your mind relax can only be good for you. And that's basically activating the vagus nerve, saying, I want you to give the brain a signal that it's okay to repair, because we can only go into that repair state when we're in the parasympathetic side of that autonomic nervous system, right? So actually manually trying to get ourselves there is a really good thing. Even if it's not, even if it's not the silver bullet, can only be good for you to help the body into a space where you create an environment for repair to happen.
Yeah, and I like your analogy of there being something being shifted, because I use a not dissimilar analogy myself. I think, the autonomic nervous system is the nervous system that controls what we don't control. I mean,
Right,
it's
right.
and
Apart from the breath, we can do that, but it
oh
will
yes,
be
but
automatically.
so
But
in
of course,
health, the autonomic nervous system chugs away
yeah,
without us
in
thinking
the
about it.
background,
It's
exactly.
always in the background. And I think the concept of therefore being able to intervene and manipulate your autonomic nervous system by conscious activities is
Mm.
something that is often foreign to most people, because it's not something that they realize is an issue, because normally nobody thinks about how quickly they breathe or
Yeah,
any of those things, or what happens to their blood pressure and heart rate. It's not an issue for them. That's controlled by the autonomic nervous system. So
yeah,
I think absolutely I agree that the approaches that you are talking about are likely to be far more effective than certainly pharmacological intervention, or certainly should be part of an adjunct treatment. So
yeah,
it is about resetting it. I do think that it is about something that it's almost, it's like having an an autonomic, and like a thermostat for
yes,
temperature in a room has
yeah,
been reset, but it triggers at the wrong temperature. And the similar analogy is that in your body, the autonomic nervous system seems to trigger at completely the wrong time. Um, and so and that affects the breathing, the heart rate, all those things. So I agree exactly with what you've said. And I actually routinely recommend that as part of treatment for autonomic dysfunction, that the focus should really be on the physical um, types of techniques
mm,
that you teach, um, more so than actually drug intervention.
yeah. And I think the reason why, perhaps prior to COVID, people found that really hard is because there just wasn't a place where people could go where everyone was in that recovery mode at the same time. Because it's actually really hard and quite boring
Yeah,
to do the work. You have to do it 2 to maybe 3 times a day for it to really be making a difference at any kind of, noticeable speed. And so in order to do that quite well, you kind of benefit from doing it with others. So there probably wasn't anything really out there. I definitely don't think I've come across a program quite like the one that we've evolved. And I know there's other people kind of providing recovery type programs now online. But I think with that sort of focus on just do the work, 2 to 3 times a day, little pieces where you're constantly bringing the body and the mind down to that kind of state of it's safe, I'm okay, you can repair. And it's actually incredibly important for people who are on this kind of journey, because it's a very stressful journey and it's a very, very hard journey to be on. And it's isolating. So, again, it comes back to that doing it with others will help you stick to the protocol. Great. Okay. So hopefully people are beginning to understand the role of the vagus nerve in this. Yes, it is involved. It's the thing that almost switches on the rest repair side of your autonomic nervous system. And it can become almost kind of switched off as a result of this virus. So if that's in layman's terms, don't quote me on that. Okay, let me come to another question. So neuropathy, and we've been talking about the fact that this is a multi-system event that goes on in the body. And some people are really wanting to know, why do we have weakened legs, neuropathy in knees? What's happening? Why might this occur? And in some ways we've sort of touched on it, but maybe, there's more that you could add at this point.
Well, so neurosensory symptoms are a common manifestation of long COVID. And again, I don't think there's one single cause or abnormality for that, because there's quite a difference or heterogeneity in presentations.
Mm.
What we have observed, however, is that there are a group of patients who get really quite nasty neuropathic pain.
Yeah.
So nerve pain that we think may be caused by some inflammatory reaction within the very small blood vessels in the skin.
Okay.
And almost what we would call a small vessel sort of vasculitis, where you get inflammation of those tiny little blood vessels that supply the nerves in the skin.
Mm.
And there is this condition known as small fiber neuropathy, where if you do standard nerve conduction studies, you often will not find an abnormality because it's looking for what's called a large fiber neuropathy. But I've been fortunate enough to work with an excellent neurophysiology called Dr. Tom Tidswell, who is a brilliant neurologist and neurophysiologist who has examined a huge number of patients with both acute and long COVID neurological problems. And what he identified, so his observations are that from the examination of acute COVID patients in hospital and, for example, on intensive care, he identified this group who have this small fiber neuropathy, which he think really behaves like very similar to patients who've had a small, what we call a small vessel vasculitis. So that's inflammation in the small blood vessels. And as he sort of examined more and more patients who have long COVID, then he's also begun to identify in some, not in all, but in some, that has a very similar manifestation. And so it wouldn't be a huge surprise if that were to be the case, because we know now that there is interesting emerging work looking at endothelial inflammation. So that's inflammation of the lining of blood vessels. And that can cause activation of clotting factors in the blood and very small little clots. And you're probably aware of a lot of the interest in microclots. And so it is plausible that some of the severe neurosensory symptoms that patients experience in their limbs, particularly in the, may be rooted in some form of small vessel inflammatory problem that then affects those tiny nerves. Now, in some, we've been able to identify those abnormalities through a specific type of test called a thermal threshold test. It's a form of neurophysiology, which is not new. I mean, this is, it's a well-recognized neurophysiology diagnostic modality for looking at small fiber neuropathy. But so in some patients, we have identified that. Not in all, but we have in some. But, sometimes where you get such subtle abnormalities they're often maybe beyond the resolution of some of our tests.
Right.
And I know that I've seen patients who've had these terrifically bad neuralgic pains after COVID, but also I've seen some patients who've had it triggered by COVID vaccination.
Yeah. Oh gosh, yes.
And then really, in fact, I saw, I think a few months ago, literally within the same month, I saw, I think, 5 women who had developed severe post-vaccine neuralgic pain.
Wow.
In the limb pain. I mean, really quite striking. They're totally independently presented in terms of you couldn't. So really, really bizarre to see that in such a short space of time. But it just shows that there must be some. I guess spike protein triggered inflammation, and is a plausible hypothesis that it's rooted in a small vessel sort of inflammatory problem. Again, this is these are interesting hypotheses, but this is not proven. But I see it. My colleagues see the presentations.
So if someone is suffering from this kind of extreme pain and they're going to their GP, and the first round is, okay, let's do a series of bloods. Okay, well, your inflammation markers are normal.
Yeah. Well, it wouldn't show up. It wouldn't show up in. I wouldn't expect this to show up in a blood test, because this is very much a tissue-based problem. And so
how does someone push for a little bit more help with this kind of thing? Because some people are kind of not getting past that first hurdle.
Yeah. Well, I don't quite understand that, because if somebody is reporting severe post-viral or post-vaccine neurological symptoms, so either neuropathic pain or neurosensory symptoms, I think they should be investigated. And so if the primary care clinician feels able to do that and to manage that, that's fine.
Mm-hmm.
But if they don't, then I think it's reasonable to ask for advice of somebody who is seeing, lots of patients with post-viral neurological symptoms.
I mean, because not everyone has a long COVID clinic in their area specifically. So what department would they be asking for a referral to?
Really neurology, because I think even my experience of long COVID clinics are quite broad brush. They don't,
they often don't have a doctor in them.
Yes, and they certainly don't have a neurologist in them.
No.
So, for example, at UCLH, the neurology service is completely separate. I mean, it's based at Queen Square, and they've got a series. They've got a group of really enthusiastic neurologists who've taken an interest in the subject and discuss patients. They have a multidisciplinary meeting every week to discuss post-COVID neurology. So they've really become interested in it. And, it doesn't matter whether you can't, I think patients accept that even if you can't treat everything. There may not be a treatment. But I think acknowledging the problem, try to identify what the nature of the problem is, and to come up with a strategy to help people through it, I think it's the least you can do. And it's a sort of minimum duty of care, I would have thought. It doesn't matter about whether it's COVID or whatever it is. I mean, that, if somebody presents to you with distressing symptoms, the task of the attending physician is to try and formulate a diagnosis and a treatment plan. And so, that's all you can do. And I think as long as
it's important to just keep asking for help if you're.
But I think more and more that I see there is a better understanding of post-COVID syndromes. There's more work. So, for example, all the things I've talked to you about, we've recently published a guideline for GPs, which is in the public domain. It's in Guidelines in Practice. It's not, it's based on our observations. It very clearly says this is how we practice it. But we've put that out there, and more, certainly primary care clinicians are increasingly willing to prescribe some of the very simple meds. I mean, after all, that we are recommending. That even a year ago, we met with awful resistance.
Yes. Well, I was doing a chat with Deepak Ravindran, who's one of the heads of the long COVID clinic. You may know him. up at the Royal Berkshire Hospital, and we were talking to a group of doctors with the lifestyle medicine cohort. And one of the things that came up was, not everyone was comfortable prescribing antihistamines. And we needed to have a conversation about how it was a pretty low hanging fruit and that it really did make a difference to people. And that, think that to kind of loosen the edges of their kind of, their strict sort of prescribing on that one might have been something that they could play around with, or just read more about to understand why this might be helpful.
It's difficult because, I think that the system that we work in has very much evolved as that new medicines or licensing for new medicines is based on the outcome of randomized, controlled, ideally double-blinded, controlled trials. And I think that's how we've evolved. And to some extent, that's quite right, because that is the best way of assessing the effectiveness of a new treatment. The problem is that system isn't able to adapt to the fact that you've got a tsunami of patients who are suffering with terrible problems after a new viral infection. And it's that inability to adapt quickly from a pharmacological perspective, which is why there's so much frustration. And and it's sometimes not even in the hands of the individual clinicians. There are restrictions in formulary guidelines in prescribing, and often I think that a lot of colleagues in primary care, and also I know from my own experience in hospital medicine, that one's hands are tied. You can't, I could not have done anything that I have done at UCLH.
Yeah.
And it's not the fault of UCLH itself at all, which is an actually brilliant place to work from. I've been there, trained there, been there since I'm part of the furniture there. But in terms of actually just doing stuff that's slightly out of the box, even though it's pretty benign, and we're talking, from my perspective, about antihistamines. I mean, it's not toxic treatment.
No.
I wouldn't have been able to do that, and I certainly wouldn't be able to write up 300 cases. But that just wouldn't have happened.
No,
it just would not have happened. And so that is, therein lies the problem. And I can't see any sign of that particularly changing, because from that perspective, it is inflexible. But you'll get a completely different side of the argument from somebody who is firmly wedded to that system. And I've heard all the arguments before.
Yeah.
So I can only give my opinion. I think that I'm not sure I agree with that inflexibility when you're dealing with the current problem. But there are others who don't share the same view as me. And I don't want to sit here and say that I'm right and they're wrong.
No.
I do have a difference of opinion from that view. And obviously, that's not how I practice. But it is a difficult one. But I think, unfortunately, that's why a lot of patients are very frustrated, because of that inflexibility.
And it's the system rather than, as you say, that the individual not wanting to help. It's the system that they sit within that makes it.
I think there are some really, very enthusiastic, passionate clinicians who are restricted by the system. I think that there are also a group who are not quite so enthusiastic and like to use the inflexibility of the system to justify their actions.
Because we obviously know of people being prescribed H1 and H2 blockers, and then someone else will come along and go, mine won't even talk to me about it.
But it's not just long COVID. I mean, there's huge numbers of other similar things. I mean, without wanting to digress, but I mean, we talked about hormone health recently. You're seeing the huge interest in the media about access for women to HRT. At least discuss hormone replacement therapy. Well, you may not be surprised about how difficult that is for many women. And I honestly get so many letters from GPs saying that they won't initiate HRT either because they're not allowed to, or because they just don't know how to. Now, how can that be right? And that's a major flaw in training and education. So a lot of these problems are deep, rooted in the system. But the flip side is, if it's a complete free for all, then you get some of the things that go on, for example, in the United States, and some of the medicines that are prescribed. I could never do that, because these are far more toxic and potentially dangerous. And I personally wouldn't feel comfortable doing that at all. So it's about getting a balance. I
Yeah.
think the most important thing, again, is about working with your patient and saying, look, this is the current state of play. This is the evidence or lack of evidence. This is a potential treatment that you could trial. These are the potential downsides. It is not licensed, but I'm happy to work with you if you want to do this. The vast majority of people given presented with information in the right way will make a decision that they do or do not want to. Now, and it's actually definitely not the case that every single patient I've seen has immediately started on the same treatment plan that I've given to the others.
Sure.
Some patients said, well, actually, that isn't for me. I don't want to do that. I'd rather try other strategies. And that's absolutely fine as well. So I think that's the way around it, rather than be totally inflexible.
Yeah.
But unfortunately it is. But I do think things are improving. I think as more people understand more about long COVID, about what's out there, about the sorts of treatments, I think I've found that many colleagues now are much more willing to prescribe or to continue prescribing some of these meds, and which is really positive.
It is positive. And I think, more and more people are really beginning to kind of piece together, actually, this does affect all of my systems. It will affect my hormonal system. It will affect my nervous system. It will affect my respiratory system at some point. It does give me pain and inflammation, and sort of beginning to almost find reassurance in the normalizing of that, which is where groups and support groups really help people, because they can type into something, about whatever pain or, a hormonal thing, or is it worse for you to, a week before you're due your menstrual cycle, and 500 people come back and go, yes. And, oh, that's great. Then, okay. So what are you doing about it? So, and I know HRT has helped a lot of people, and it doesn't help everyone. So, it's not, again, there's no silver bullet. It is about, really working to find what's right for you as the individual. And it is just about being persistent, keeping on going back and asking for help with the GP, or, just having another conversation, maybe with a different GP if you can, if you're not getting quite what you need from that first one. Just keep having the conversations and don't give up, because at some point you'll find the right set of tools that make you feel like, this is making a difference now. And I think that's key, isn't it?
Yeah. I mean, the other thing I think is also, I think, worth mentioning, it's just in a logistical, from a sort of practical perspective. If you think, we're now an hour and 20 minutes into this discussion.
No.
We've touched on a tiny area of this topic. It's hugely complex. There's no right answers. It's difficult to be dogmatic about one direction or another, but it's about an open conversation with the person that you're treating. Yeah. Now, if you're an overwhelmed, overworked, poorly staffed NHS GP who is allocated 10 minutes per consultation, how can you possibly address this sort of problem in that time frame? You can't. And I actually think it's unfair on the patients, but it's also unfair on the staff. I mean, you just can't expect, an NHS GP to be able to have the time to be able to consider the complexity of a condition such as long COVID in 10 minutes.
Right.
So I think from every angle you look at, I think although people get frustrated with, their GPs or the access to them, I completely get it. Why, unfortunately, that's why they're leaving in their droves, because, how can you work that environment? So it's a double whammy. So I think it's really tricky, and I don't want to I'm actually, I just was trying to present a balanced picture of why it's not so straightforward to be able to be flexible in a system that really can be quite restrictive when you're working in it. And so that I think therein also lies the issue. So it is difficult. And then, of course, access to long COVID services can be limited. And then some people's experiences of long COVID services are variable depending on what's offered and what's in the country. So it goes on. And so all we can do, I think, is to share good observations with patients and with colleagues to say, look, this is what you can try. This is what you can discuss, just to make it a bit easier until there is, more robust evidence to then say, this is absolutely the treatment protocol for the UK. Because obviously we're a long way from that at the moment.
I should think we'll be a long way from that for quite a long time. Actually, just one question before we finish now that's really just come into my mind. You said that you had written up some guidelines that, you'd been sharing with GPs. Is that something that you can make available to us? Because there might be GPs watching this. It would be great.
Yes. So that guidance is co-written by myself, Harsha Master, who is a brilliant GP who runs the North, I think it's Hertfordshire Community Long COVID Service, who is one of those, extremely hardworking, absolutely enthusiast about the subject, who's been very open to trialing different things. She has been prescribing antihistamines right from the early days. So she's got a really good long COVID service there. So I wrote it with her and her colleague, and Dr. Nicholas Gall, who you may know, who is an expert in autonomic dysfunction and POTS.
Right.
And then with Louise Newson and my wife, Sarah Glynne, who have taken an interest in hormonal health and long COVID. So we wrote a pragmatic guideline, which is really just say, look, this is what we do. Yeah. I mean, you don't have to do this but these are
we're doing. Yeah.
And this is what we're doing. And that's now, you can just look that up if it's in the public domain, but I can certainly send you the link to that.
I'll attach it to the interview.
No, I'll send it. So it was, I think, published about 3 or 4 weeks ago. And it's not a national guideline because it's not, it's not a MICE guideline. Sure. It's just our, this is what we do. And
this is what we're doing, and we're seeing some good results.
If you're interested, this is something you could use, maybe make you feel a bit more comfortable about prescribing some of the meds that we are using. Great.
Because I know that some people will be really delighted to have something perhaps that they could take in their hand to their GP and go, this, please have a look. Yeah. And then can we talk about it? Because it's quite difficult to perhaps, people who are suffering and the journey of long COVID are living and breathing it day in, day out. They're reading about it. They're talking about it. They're reading the research. They're reading other people's stories. And they might have a GP that's just not as interested or doesn't have as many patients on their books. So for them, learning about it outside of the office hours is probably a little bit less of a priority. And so to be able to take something quite condensed like that in would be a gift, I'm sure. Although who wants to be given homework? But anyway, hopefully. But listen, Paul, we've taken up lots of your time, and I'm looking at all of these questions that we haven't really touched on. So apologies if you're watching this interview and go, oh, but you didn't touch my question. We'll just have to come back to Paul at some point and pick up.
Well, Susie, I'm happy to do another session.
Great.
And if you want, we can literally do a rapid fire Q&A.
Great.
I won't waffle on about other stuff. And
it's all interesting. I love it.
and then we can do a second session. I can literally just do a Q&A session on that. And
like a quiz. We'll do it.
We'll keep it punchy, if that would help.
I'm sure that would actually, because I'm looking at this going, we've sort of answered a question, but perhaps not. So I'll take you up on that one. That's fantastic. But for now, Paul, I'm going to say a huge thank you for your time and your wisdom and your experience. It's been an absolute pleasure. I'm going to
nice to speak to you, and good, and thanks for your help with the patients that I've commended to your program.
Thanks so much for listening to the Rest, Repair, Recover podcast. If this episode brought you comfort, insight, or even a little spark of hope, I'd love it if you left a review. It really helps more people find this kind of much-needed support. And if you know someone that needs to hear this too, please share it with them. I'm sending love, as always. Look after yourselves.